Okay, so today we're going to be looking at polycystic ovarian disease. What we're going to begin with is the pathophysiology. Primarily, we don't really know why it happens. What we do know is that you have a high amount of LH production relative to FSH. And the ratio between this is oftentimes 2 to 1. So what does this cause? Well, primarily it's going to cause derangement in the sexual hormones. And that is going to be your testosterone and your estrogen. LH activates your theca cells. Theca cells are found in the ovary, and these will produce testosterone. Now, usually the granulosa cells will convert the testosterone into estrogen, but granulosa cells are activated by FSH. So if you have low FSH, you're going to have decreased granulosa cells. And so your testosterone to estrogen is not going to occur. And so primarily you are left with a lot of testosterone. Now, in obese patients, however, in obese patients, they have a lot of adipose, and adipose has aromatase, which will convert testosterone into estrone. So in obese patients, they not only have high testosterone, but they also have high amount of estrogen. And this can oftentimes lead to other problems such as endometrial hyperplasia, which is the effect of estrogen. Now, on top of this, for one reason or another, we also have insulin resistance. In other words, it's kind of like having diabetes type 2. Now, why does this occur? It's due to not at the receptor level, but the post-receptor level. Something goes wrong with the transduction, and it's not really known what is going on, but something with the insulin receptor and the signal getting transduced intracellularly, it's not working. And by the way, this doesn't really have to do with them being obese. This occurs in lean patients and obese patients. So it's something independent of being obese or having too much fat. Now, this can lead to some complications. Primarily, it can lead to metabolic syndrome. Metabolic syndrome is when a patient has diabetes mellitus type 2, they're obese, and they start to have cardiovascular symptoms, and they develop hypertension. And on top of all that, they get dyslipidemia, which is generally caused by testosterone, where you have low HDL and you have a high LDL, which is going to increase risk for atherosclerosis and the formation of plaques. Now, both of these combined lead to a decrease in sexual hormone binding globulin. So what does this mean? Well, sex hormone binding globulin binds testosterone, and while it's bound to testosterone, it's not active. So you get increased amount of free testosterone, which just further accentuates the problem with having high testosterone from the LH. Now, this also helps explain why some patients who may have normal testosterone level but show symptoms of hyperandrogenism, such as the hirsutism and the acne and all of those things. So what are the symptoms that this can develop in patients? Well, first of all, how is it diagnosed? It's diagnosed when 3 conditions are met. The first being anovulation, usually primary, hyperandrogenism, and again, this is going to be highlighted when they have, hirsutism, severe acne, alopecia, and finally, polycystic ovaries. And of course, to see this, you do need to do a transvaginal ultrasound to detect this. And usually 12 is the number, and greater than 12 cysts is what you're looking at, and also, you know, a large ovary can suggest this as well. Besides these three main symptoms, there also are other problems as well. Primarily, we have irregular menses, and so what happens is they have high estrogen, like we discussed earlier, and there is no progesterone, because in order for there to be progesterone, you have to have the development of the follicle, and you know there has to be progesterone withdrawal, and there has to be ovulation, and then progesterone develops, and then there has to be progesterone withdrawal to lead to normal menses. But since there's no ovulation, they never have progesterone, and so you have estrogen unopposed, and that leads to high levels of endometrial hyperplasia. So the endometrium becomes really thick, and it becomes so thick that eventually it, just from the sheer weight, it starts to fall down, and you have heavy irregular bleeding, also known as menometrorrhagia bleeding. Okay. On top of this, you get something called acanthosis nigricans. This is kind of like a darkened color, dark coloration to the skin, in the folds of the neck, sometimes in the fingers, and this is due to high amounts of insulin. There's also infertility, or in other words, subfertility. Developed again, they're not having normal ovulation, so of course this is going to be developed. We also talked about metabolic syndrome and all of those. This is going to be the hypertension, cardiovascular symptoms, dyslipidemia, obesity, and diabetes type 2. And so this is very, very, this needs to be addressed right away to prevent future heart attacks and other symptoms as well. And finally, due to the androgens, there's going to be some hirsutism, acne, alopecia, and this has a lot of psychological effects of the women. Obviously, this isn't attractive to them, so they kind of have low self-esteem, and it's something that worries them a lot. So when you do come across a patient with this, what type of investigation would you do? Now, you have to understand, even though we have, a three-step diagnosis system. Oh, by the way, I forgot to mention, in order to be confirmed, you need to have 2 out of 3 of these symptoms. So anovulation, hyperandrogenism, or polycystic ovaries. If you have 2 out of those 3, then it gets diagnosed. Still though, this is primarily a diagnosis of exclusion. So we need to exclude all the other factors of anovulation. So this is going to go down to the thyroid, where you're going to be testing the thyroxine levels, T3, T4, and your TSH. You're going to want to, obviously, hyperprolactinemia, so you want to check the prolactin levels. You want to rule out primary ovarian failure, and with this one, they'll have high FSH, high LH, and high estrogen, which is different than polycystic ovarian disease, where your LH will be twice your FSH, and your estrogen and testosterone will be high, so that's slightly different. You also want to rule out late onset congenital adrenal hyperplasia, and just as a quick recap, that's a problem with the adrenal gland, where they do not have either 17 alpha hydroxylase, 21 alpha hydroxylase, or 11 alpha hydroxylase. So to do this, you're going to primarily look for 17 hydroxyprogesterone levels, and you're going to monitor those in the morning after they're finished fasting. You also want to rule out androgen tumors, and you would do this by looking at, of course, the androgen index. The androgen index is going to be your testosterone levels divided by your sex hormone binding globulin times 100. And you can also check your DHEAS, which is the testosterone that's produced by your adrenal glands. And if they have symptoms of Cushing's, you might want to rule out Cushing's, and this is done with the dexamethasone, the low dose, and the high dose. Now, if all of these come back negative, you're going to then want to do the transvaginal ultrasound. This is when you start looking for polycystic ovary disease. If you have greater than 12 cysts in the ovaries, that pretty much confirms it. And after that, you're going to want to do your 2-hour glucose tolerance test to see their insulin sensitivity. You're going to want to do their BMI. You're going to want to look at their lipid profile, and you're going to want to look at their BP. Again, metabolic syndrome is what we're worried about here. You want to address that right away. So what would be the treatments for polycystic ovary disease? Well, initially, just generally, you want to have them, do some diet and exercise. Why is this? Well, first of all, it addresses the metabolic syndrome, so you want to decrease the effect of the metabolic syndrome. Also, this helps increase insulin sensitivity. And this by itself can address many issues, such as a fertility issue. They've shown that even a 5 to 10% decrease in weight can help regain some of the fertility that they might want. Now, after this is pretty easy to do. It's good for everyone to do. But after this, depending on the patient's requirements, you would treat differently. So some patients might be more worried about the hirsutism, the acne, and the alopecia, so I call that beauty. And other women might be worried about their fertility. And unfortunately, you do need to pick one over the other. Why? Well, to not only beauty, but the anovulation and the abnormal menses. So the first form of treatment for this is just going to be to give them oral contraceptive pills. What does this do? This primarily, the first reason why we give this is because if they have unopposed estrogen, this leads to endometrial hyperplasia, which of course then can lead to endometrial cancer. So you want to avoid that. So this is one reason why you want to give that. And of course, this has the other effects of regulating their menses and all those as well. And not only that, but when you give the OCP, the estrogen begins to inhibit the LH. This will decrease the androgen, and this will help some of the hirsutism and the acne situation. So this helps more with beauty, but of course, if you're taking OCP, it's going to lead to infertility. So you got to pick one or the other. The next treatment would be anti-androgen. And of course, we know that the hirsutism, the acne, and the alopecia is caused by this. So this would directly address that issue. And finally, you also want to give metformin. And actually, metformin you can give, both categories. This is kind of a general treatment to increase insulin sensitivity and, of course, combat some of the metabolic syndrome and all of those. So now, if fertility is the issue, then you probably want to, stop. You can't give OCPs. So what you want to do is you probably want to give something to increase ovulation and increase the chance of permeability. So you give clomiphene citrate. This is going to help induce ovulation and increase the chances of becoming pregnant. And there's another treatment, surgical treatment, called ovarian drilling. And this is when you drill 4 holes, 4 to 5 holes into the ovary. It's done laparoscopically, so it's fairly invasive, but it does have a high chance of success. About 70% of women who undergo this do end up getting pregnant, so it's really helpful. How does it work? They say that perhaps because one of the problems with polycystic ovarian syndrome is the ovary becomes really dense, and there's a lot of stroma, so this helps reduce that, and that somehow helps with fertility and ovulation. So hope that helps. See you guys later. Bye.